Alright guys, so this is the third video in our series of continuing the cardiovascular system now of the online step 1 USMLE QBANK presented by USMLE Forum of Pakistan. So as we have stated before that every question has in itself different tangents to discuss, but I would try to be concise and would discuss the most important high yield factoids that you must know to give your exam. So, starting off with the first question, 48-year-old man with type 2 diabetes, it's well controlled, has intermittent retrosternal chest discomfort, he has no hypertension, normal blood pressures, and he has no cardiovascular disease history. During an exercise treadmill test, this is basically known as a cardio stress test or an exercise stress test, basically which a patient undergoes exercise and an ECG machine is plugged onto the patient and he undergoes exercise, and then the ECG shows the changes that are undergoing in the heart during the exercise. So for people that face exertional angina or exertional difficulties in their conduction system in the heart, the ECG will show that, right? Those kind of patients don't really have any problems regularly in normal routine work, but they do face problems and they do face retrosternal chest pain during exertion or exercise. So that's why this test is used to for evaluate coronary artery disease in its initial stages. Right, so he undergoes this test and he exercises for 7 minutes and he has no chest pain. So his basically the test is normal and ECG is also normal, so it shows no ischemic changes. And the heart rate increases from 70 to 132. He faces no problem. The blood pressure also rises. The important question, which basically starts from here, is what parameter would be decreased during peak exercise compared to the rest in this patient. Basically, what they're asking is what parameter would be decreased whenever exercise changes occur in our body. So, for to answer this question, you have to know what changes occur in the body during exercise. And I have a good illustration for that, but first of all, we need to discuss a few options right here before going on to that. So looking at the first option, the cardiac output. Now, cardiac output is going to increase, and that is logical because in exercise, when the sympathetic drive is increased, the body needs a lot of blood. The body needs high volume, and it would make no sense for the body to decrease the cardiac output. So the cardiac output increases. So it will never decrease, especially not in states where more cardiac output is needed. So this is the wrong answer because it's logical and it's smart enough to understand and to predict that the cardiac output of the heart will increase. All right. Talking about the left ventricular and diastolic pressure. Now, you have to understand that left ventricular and diastolic pressure, the LVEDP, in most situations is equal to the amount of blood in the heart at that moment because it is the pressure that is exerted by the walls of the heart. So, if more blood is in the heart, more pressure will be exerted, and hence this value would be higher, right? In some situations where there is less blood in the heart and still the LVEDP is higher are situations such as restrictive cardiomyopathy, in which the walls are already tensed, so it doesn't really depend on the amount of blood rather it is a pathology. So the LVDP is already higher, and the LVEDV, which is the left ventricular end diastolic volume, is lower in that situation. But in normal situations, these both are equal physiologically. You can say that the amount of blood in the heart is equal to the left ventricular end diastolic volume, which is equal to the left ventricular end diastolic pressure. So going by that, if the body needs more blood and the body is increasing the cardiac output, which means that there is more blood coming into the heart and going out of the heart. So this in itself would increase, this would not decrease, right? So the cardiac output would increase and this would also increase. The pulmonary artery systolic pressure, going with logic again, more blood is coming into the heart, is going into the pulmonary system for it to get oxygenized, and then it is going towards the rest of the organs. So if more blood goes into an artery, this is a physiological law that if this is an artery, and if more blood is coming and pushing the walls of the artery in itself has an automated mechanism where it pushes onto the blood. This is an automatic mechanism to control the flow of the blood in a specific artery, because if this mechanism did not exist, then even higher volumes in states of hypervolemia, the vessels would just keep on increasing and increasing and the organs would get overflooded. So this is a physiological mechanism in which you have to remember. So if more blood is coming into the pulmonary system, then the artery systolic pressure would definitely increase. So this is a wrong answer also. They would increase to keep the blood in check, to keep the blood flow in check. So this is the wrong answer. So going by logic, we have just cancelled out three answers today. So systemic systolic blood pressure. Now, one more rule that you have to understand is that cardiac output is basically not equal, but it is dependent on the systolic blood pressure. And the SVR, or the systemic vascular resistance, which is our next option, is equal to the diastolic blood pressure. Not equal in terms of value, but equal in terms of that if one value changes, the other changes as well. So that is what they're dependent on, right? Mostly they will give you a question in which there is an old man and he has a higher systolic blood pressure, or he has a higher diastolic blood pressure. So he has a higher diastolic blood pressure, and they ask why is the diastolic blood pressure increased, and the answer would simply be due to the increase in the uh, systemic resistance of the body. So that is how they ask questions in the NBME and the USMLE. That is a very important example that you have to remember. So this would also be increased because, as we've discussed before, cardiac output increases. So if cardiac output increases, the systemic systolic blood pressure will also increase, right? If you remember, we discussed it right over here. So they both are related to each other. That's very unlikely if one increases and the other decreases. That's very unlikely. So the correct answer by elimination is total systemic vascular resistance. And if also by logic, if we know the factoid, the high yield factoid, which is on the next slide, because I have saved this picture for you to see, so that you can pause the video and read it out. So if you not just look at all of this and just concentrate on this section right here which says total peripheral resistance. Now, whenever I get pages like this, and it's very overwhelming, so what I do is I concentrate on one thing that I would get out of this page. So one thing that I want you to get out of this page is what happens to the total peripheral resistance. What do you have to know? So what happens is that vasopressors cause vasoconstriction, so they would obviously increase the resistance that the blood is getting. That is very simple. How does exercise and arteriovenous shunt, changes the total peripheral resistance? That we have to understand is due to when you're exercising, the skeletal muscles dilate because they want more blood to come towards them. So when they dilate, more blood comes in the muscle, and hence the muscle gets its nutrients. When the muscles throughout your body dilate, the vessels inside the muscles also dilate, which in turn decreases the total peripheral resistance. Now, how does arteriovenous shunt or the AV shunt, as we call it, how does that decrease? Because you see that there are arteries, and then there are capillaries, and then there are veins. So if arteries pass directly into the veins, they are skipping a road. So this in itself is a shortcut because there is no break in between, right? If you come from, let's say, point A to point C, you have to stop at point C, and then you have to come to point B, right? So basically, you will stop in between, and this will take you more time, right? This will take you more time. You would have to slow your speed if you are traveling in a car. But if you're traveling in a car and you come directly from A to B, now this in the diagram this looks it's longer way, but there is no stop in between. So you can, if you're driving in a car, you can speed your way from A to B, from arteries to the veins. That is how I remember that the blood speeds its way from the arteries to the veins, and hence it encounters less resistance. It encounters no breaking point, whereas in this pathway, which is physiological, it encounters a breaking point. And this is important because we cannot just have the blood unchecked. There has to be some resistance to it. There's also a question in the NVMEs where they ask what point, what point in the circulatory system of the body gives out the most resistance, and that answer is capillaries. All right. So I guess this is clear. Moving on, you can read the page by itself, but I think these concepts will be discussed in the future, so I'm not going to waste more of your time. You have to do remember this graph, this one. So this is the normal, and increase is shown by here, vasopressus, because the increase is basically the inverse of this fraction that is written, cardiac output upon venous return. So if total peripheral resistance increases, the cardiac output would decrease, right? So it is an inverse of this fraction. Okay, moving on. But just remember what I explained on the previous slide, the concept of LVEDP, LVEDV, cardiac output, SVR, the automated physiologic reaction, and this atriovenous shunt and exercise concept. So, pathologists investigating age-related vascular changes by examining post-mortem specimens from teenagers, right? So you have to keep in mind the age. In one case, a 14-year-old male from a traffic collision demonstrates multiple small faint yellow discoloration and slightly elevated above the aortic lining. No cardiac abnormalities are identified. The deceased had no relevant medical history or family history. Which cellular component would be most abundant in these early vascular lesions when examined microscopically? Now, they are talking about teenagers, and it's very normal. It's a normal teenager with no pathology. So you have to think like that, that there is no pathology, right? So you have to understand this is the first clue. That the teenager, always concentrate on the ages that are given in the question. Those are very important. You have to know the description. Small faint yellow discoloration slightly elevated above the aortic line. These are fatty streaks, right? Fatty streaks. And this is basically the first step in the formation of atherosclerosis. And these are normal. These are present in every normal person. These are normal, so you have to keep that in mind. This is not atherosclerosis. This is the first step. first step in the formation of atherosclerosis. This is normal, all right? And they're asking what component would be most abundant in these vascular lesions. So what component will be abundant in the fatty streaks? What concept they're trying to give you is basically that what component is involved in the formation of atherosclerosis. That's the main concept. If you know what component is involved mainly, then you can get this answer right. So logically, if you want to cancel this out, so we can cancel out neutrophils because they're mostly involved in inflammation and infections. And we can also cancel out eosinophils because they are also involved in infections and inflammation. So these two answers can be cancelled out. Fibroblasts are involved in scar formation, and we are not having scar formation. So you have to remember that this is involved in scar formation or connective tissue disorders. This is not a connective tissue disorder. If this would have been, they would have given you something. Mast cell is also not involved in atherosclerosis. It is involved in infections, inflammation. This is involved in hypersensitivity reactions, allergies. So this is what mast cells involved. You can write allergies, right? So the only logical answer left is macrophages. Now you must be saying macrophages are also involved in infections. You have to understand that macrophages are basically involved with the uptake of LDL, and this is what you need to know. Right? This is a fatty streak. Now you can see this is slightly elevated towards the lumen. Right? This is the normal lumen, and this is slightly elevated. So this is a fatty streak. And if you can see the progression, this basically involves macrophages. So you need to understand that macrophages are what cause these fatty streaks. Something more to help you remember is that macrophages are involved in chronic processes, and this is a chronic process. So this is another pointer for you to remember that macrophages is the culprit, right? Natural sclerosis, I would highly recommend you to remember that macrophages are mainly involved in everything, right? So they take up the fat that is lying there in the arteries, and because endothelial cells are also damaged, so what they do is they start accumulating there, and then they release these cytokines which start proliferating the connective tissue there, the fibroblasts there, and then what they do is they form an atheroma, which is basically the Coma is basically the gathering of any tissue. So they form this atheroma, and this over time gets deposited and gets heightened, then starts to block the lumen, which in turn gives its classic symptoms. So you have to understand, right? Fibroblast growth factors are involved to create connective tissue. They are not involved in making the fatty streak. So you have to remember that. Keep that in mind. Keep this diagram in mind, and keep this labeling in mind as well. Foam cell is basically a cell which has lipid and macrophages with lipids basically inside them. So you have to keep this in mind. This is important. All right, moving on. So this is basically a 53-year-old female hairstylist, and is having persistent aching discomfort in both legs, and it is interfering with her work. So this is a pathology. We have to take care of it. She has no history of trauma and similar symptoms previously. There is a past medical history of migraines and chronic hepatitis C infection, which has not received treatment. You have to keep that in mind. She has a smoking history and no alcohol. Abnormality is affecting which of the structures most likely responsible for the patient's symptoms. So basically, what they're saying here is the first clue is persistent aching discomfort, which is interfering her work. So basically, she's having pain. Excuse my writing. She's having pain due to work, right? So you have to think of a PAD in this case. A 50-ish female patient with a smoking history, with migraines, you have to think of a PAD. Pain from work. Simple. Think of a PAD. Always. Always think of a PAD. Right? They're asking which structures is it affecting. So once you get the diagnosis, once you remember that pain from work is PAD, once you remember this, then it's quite easy because in itself it says peripheral arterial disease. So basically just look at the options and choose the one that is correct. Arterial intima. Why wouldn't other options be in this case? Lymphoid capillaries are not involved in any of the peripheral disease, be it venous, be it arterial. Lymphoid capillaries are always involved. There is some sort of edema given in the question. So there is no edema, so you don't have to think about the lymphoid capillaries over here. So that is wrong. Also, you don't have to think about plasma oncotic pressure because if that would have been given, there would have been some edema clue given or some liver dysfunction given. Liver, right? Or there would have been some kidney, renal dysfunction. So renal, okay? So you don't have to think about that because none of that is given. No swelling, nothing. Vasa vasaram is always a wrong answer. This is nothing. This is small arteries that supply the big arterioles. One high yield fact you can remember is that basically weakening of vasa vasorum is involved in aneurysms. Aneurysms are mainly involved due to the weakening of connective tissue, but vasa vasorum can be affected uh, in syphilis or end arthritis, and they can cause necrosis of the walls and give rise to the formation of uh, arterial aneurysms. So that you could remember that if you want to, but these are always wrong answers. Venous valve is a wrong answer because they are basically seen in venous insufficiency, right? And venous insufficiency will always present again with edema. There is no edema, so veins will always present with edema. Right, 9 out of 10 times they're going to present with edema, or they're going to present with the previous history of DVT. There is no DVT. DVT is basically prolonged immobilization and lower limb unilateral swelling and pain. So there is nothing like that. Right, she's getting pain from work. Capillary permeability. Capillary permeability will not give rise to PADs because capillary permeability has nothing to do with persistent pain in the legs, right? Because capillaries are involved in capillary beds, so they are a connection between arteries and veins. Capillaries don't basically enter muscles, and they don't have that power to have any effect. Whenever there's a patient that's presenting with an aching complaint, always think about the problem that is going on is in its muscles, right? Because muscles cause pain. So capillary permeability has nothing to do with causing pain and causing any discomfort or any pathology. If at most it is related to increased hydrostatic pressure, which will in turn also be related to edema. If capillary permeability is increased, more fluid is going to go inside the interstitium. There would be pitting edema and there would be swelling. So this is also the wrong answer. Just keep in mind the high yield fact that pain from work is PAD, and PAD affects the arterial intima. If you could see this question, this picture again, the arteries have narrow lumens. So if they are affected, the muscle will cause pain. There would be symptoms. There would be hypoxic ischemic symptoms. Not hypoxic, but ischemic symptoms. Right? But veins have a bigger lumen, right? This is the lumen of a vein. So also there are valves in the vein. So affecting the veins would simply cause the blood to leak out and cause swelling. It will not cause any muscle pain or any symptom that is covert or hidden, right? So going into this question again. So 67-year-old male, emergency department. He has shortness of breath and chest tightness, and he has history of lightheadedness and faint episodes. His medical regimen is lisinopril and metformin. The patient has maintained a heavy smoking habit. Now they're talking about a pattern that has emerged from a blood pressure measurement. What happens at inflation till 140, there are no sounds audible. But when the pressure decreases to 120, the sounds appear exclusively during expiration. At 100, sounds become continuous through the respiratory cycle. This physical finding is most characteristic of which underlying condition? So obviously you would have guessed right now that this is the most high yield part of the question, knowing what this basically what this phenomena is. So what is happening here is that when the patient, if normally when the blood pressure is taking, the sounds appear regardless of expiration and inspiration, right? But in this patient, the sound is appearing only during expiration, and at continuous, the point where the sounds become continuous is at 100 mg. So you have to understand that this 10 millimeter decrease of pressure, which is associated with a certain phase of breathing, either expiration or inspiration, a certain phase of breathing, so known as paradoxus, pulsus paradoxus, right? Pulsus paradoxus. Yeah. So what happens is that the blood pressure increases during inspiration, and what happens is that during expiration there is a difference. So basically, uh, this picture what it shows is that if there is if there is any sort of pathology surrounding the heart or restricting its action, what happens is that when you're inspirating, more blood is coming into the heart, right? Thoracic pressure decreases, volume increases, so more blood is coming into the heart. What it does is basically, if something is compressing the heart, instead of the right ventricles increasing in size, what they do is they retain their contraction, and they instead of increasing in size harmoniously throughout the heart, what they do is they start to push the interventricular septum towards the left ventricle, and they decrease its lumen. So basically, what happens is that the cardiac output decreases, and so there is a difference in the inspiration by certain 10 millimeter of mercury value. So this only that you have to know, what you have to know is this flow chart written over here, is that when in a certain breathing phase, in expiration or inspiration, in a certain breathing phase, when in inspiration it's mostly found, but in a certain breathing phase when they are talking about a change in the blood pressure, you have to know that the pathology is constrictive pericarditis or any uh, pathology that is constricting the heart. You have to know that. They have given some examples. These are high yield examples: group OSA, asthma, COPD, carbonic temperament. So you have to know. If you don't know anything else, you have to understand. You have to know that the constrictive pericarditis and cardiac tamponade are two high yield examples for that. So you have to remember both of these. So now the question is quite easy. We could figure out that this is the right answer: pericardial disease. So this is a factoid that you have to know. If you don't know pulsus paradoxus, you wouldn't be able to solve this question. So pulsus paradoxus is a high yield concept that you need to understand, right? If you don't understand it, you can comment down below, and maybe I could explain it in some other way. But just remember that if they're talking about blood pressure change during inspiration or expiration, and they've given you signs of shortness of breath, chest tightness, chest pain, tripod position, think about pericardial disease, right? All of this does not happen in any valve disease, and this certainly does not happen in myocardial ischemia. Peripheral vascular disease, it doesn't happen as well. So you have to know this fact, right? Right? Just pause and see the diagram, and then you could understand. All right. So moving on, a patient presents to the emergency department with shallow breathing and difficulty completing full sentences. He's in respiratory distress. Physical examination demonstrates prolonged expiratory phase with audible wheezing. Cardiac auscultation reveals normal heart sounds. Thoracic imaging reveals normal cardiac dimensions, but notable lung hyperinflammation with depressed diaphragmatic contours. Point of care cardiac ultrasound shows no evidence of cardiac effusion. Which of the following is a cardiac mechanism would mostly, which of the following cellular mechanisms would most rapidly alleviate this patient's symptoms? Okay, so first thing that you have to remember is prolonged expiratory phase with audible wheezing. You have to remember that this is the first high yield point, that this is for asthma until proven otherwise. This is for asthma, and you have to remember that, right? You have to remember that. That's high yield factoid. They're saying that the heart has no problems. So basically, this is not a cardiac induced pulmonary problem. This is a pulmonary organic problem in itself. There is lung hyperinflation, which again, this is the second clue that you have to remember is for COPD. You could find that in COPD, right? You could also find that in asthma, but mostly it's for COPD. This first point is for asthma, so this just corroborates the point. The question goes on to clarify that there is still no cardiac problem, so that you don't go into any other tangent. And what is the cellular mechanism, basically? So what they're saying is that this patient is basically having an asthma attack, an asthma exacerbation. So what do we do, right? In asthma, what do we do is we dilate the bronchioles. We dilate the bronchioles, right? The bronchioles are constricting, so we dilate the bronchioles. They're just asking what happens when we dilate the bronchioles. So what happens when we dilate the bronchioles? How do we dilate the bronchioles? What is the first thing that we give in asthmatic patients, right? What we do is we give them a bronchodilator. So the mechanism of bronchodilator that you have to remember is that they act on beta 2 adrenergic receptors. Bronchodilators are basically beta 2 adrenergic agonists, which is known as albuterol. Others, of course, albuterol is the most common one. So it acts on beta 2 receptors. Beta 1 is in the heart, so you don't have to don't confuse them. Beta 2 is in the lungs, so they are bronchodilators. So you basically just have to know what is the working of beta 2, then you can figure this out. So this goes to our important table of this whole table is given in first aid, but you have to know this mnemonic, which is KISS, kick, right? So you have to know that this is alpha 1, alpha 2, beta 1, beta 2, M1, M2, M3. All right. All right. So I was explaining that these are the G protein coupled receptors, and this is the mnemonic for that. So remembering S starts with the sound of SIR, so you always remember that this increases cyclic AMP. The I is an inhibitory, so it inhibits cyclic AMP, right? And the Q is a different pathway. It's IP3 DAG pathway. That's a different pathway. So I told you that the kiss-kick mnemonic is alpha 1, alpha 2, and beta 1 and beta 2. So you know that bronchodilators work by beta 2 mechanism, and they in turn work by the GS mechanism, which in turn increases the cyclic AMP. So knowing this concept, what happens is you see this is written bronchodilation, right? All of these others are important to know as well, but we will discuss them in further videos. Cyclic AMP is increased by beta 2 receptors. That's a high yield factor that you have to know. So what you have to know is bronchodilators activate beta 2. They in turn work by a GS pathway. The GS pathway in turn acts by increasing cyclic AMP. And that's it. You solve the question, right? This is the correct option. That's it. Prevention of mast cell membrane disruption. This is not the mechanism of action of bronchodilator. This is mostly the mechanism of action of mast cell stabilizers, chromoline and sodium chromolate that you have to know. Suppression of eosinophil granule release. This is the same thing as the mast cells membrane stabilization. You don't have to know the mechanism of action of that, but just know that sodium chromolate is a mast cell stabilizer. Blockade of histamine receptors on the respiratory. Histamine has nothing to do with asthma. Histamine has nothing to do with asthma or respiratory epithelium. It has everything to do with allergies. So you just remember that histamine and allergies. And I don't think, in my knowledge, there is any receptor that works by histamine and it has anything to do with clinical medicine. Enhanced calcium influx. This is a wrong answer because this would cause smooth muscle contraction. This would cause contraction, and we don't want that. So you have to know that calcium is related to muscular contraction. So if calcium influx happens, muscles will contract and the smooth muscles will contract and this will cause bronchoconstriction. So we don't want that. So this is the correct answer right here. Okay, so that's it, and thank you for watching.